Cesarean sections, or C-sections, are on the rise, and they have been for many years now. And there's multiple reasons as to why that's true. We can't just say it's because women are electing to get them more frequently, or that more emergent conditions are occurring that are forcing the C-section. That said though, if you look at the statistics worldwide, which do vary by country, it's around 20 to 30% of all births are C-section. So what we want to do in this video is illuminate some of the mystery behind the procedure itself. We're going to look at the exact tissues that are being cut through and get an idea of what she can expect during a C-section. Let's do this. First of all, there is no universal procedure for a C-section. The type of procedure that's performed depends on a variety of factors, including the doctor as well as the circumstances with which it needs to be performed, such as, is it an emergent C-section? Is this designed to save mom and baby's life? Or is this a planned C-section and this woman received multiple C-sections prior to that? So many factors come into the exact type of incision that's going to be made, but at the end of the day, there are a lot of commonalities that modern techniques share, and that's what I want to show you today. So what we're going to do is jump on over to the skeleton and look at some skeletal anatomy that'll give you an understanding of the basic layout and area that they're going to be cutting into during these procedures. Now this is a real human skeleton pelvis. Now obviously we've made a few adjustments such as the metal and the paint that illustrates the muscle attachments, but it's going to give us a really good idea of the landmarks that are in the area as they're making their incision. And again, the incision really does differ depending on the procedure they go with, but more or less, they're going to go anywhere from 2 to 5 centimeters above this area here called the pubic symphysis. You see this piece of cartilage? This piece of cartilage connects these two pubic bones, and we call that the pubic symphysis. So they'll go just a few centimeters up, and then they're also going to be going based off of these two landmarks here called the anterior superior iliac spine, or ASIS. So they're going to go a couple centimeters in the medial direction, make their transverse or curvilinear incision, and then stop another couple centimeters before they would reach that ASIS. Again though, it does depend on which procedure they end up doing, the height they make this initial transverse cut. So when they make this initial transverse cut in the abdomen, they're only cutting through the superficial layers of the abdomen or the integumentary system. So this is the epidermis, dermis, and hypodermis, or the subcutaneous tissue, which is comprised mainly of fat cells. And they do this because they don't want to cut into the muscle underneath, because that is going to increase recovery time dramatically and can be a huge risk of complications. So what they're going to do is they make that cut, and then they're going to start tearing the tissue away from itself. And this sounds kind of aggressive, but the idea here is this will lessen recovery time as well. You see, if you use a sharp tool such as a scalpel for everything you're doing, you increase the likelihood of severing blood vessels and just making it much more difficult for that tissue to heal. So they're going to use their hands and blunt ends to an instrument as much as possible to try and just reveal the deeper tissues, which are going to be connective tissue and muscle, because they're going to need to make a second cut. So once they've kind of revealed enough space, they should be able to see what's going to be called the rectus sheath. And the rectus sheath is just a connective tissue layer that surrounds the rectus abdominis muscle. And we can see that right here with this particular cadaver. So what you'll notice is we have the umbilicus, or the belly button, left on. And you can also see that, so we have the epidermis, dermis, and then deep to it, you can see all this fatty tissue. This fatty tissue is that subcutaneous tissue that they're going to be cutting through. So this is kind of nice. You can see all the layers that they would be cutting through as they do that really low transverse cut, which is often referred to as the bikini line cut. But once they do that and they've exposed enough of the area, they can see this tissue here called the rectus sheath. So all this white connective tissue, this is called the rectus sheath, and it just lies just on top of the muscle tissue, the rectus abdominis. So we've kind of cut away some of the rectus sheath to reveal the rectus abdominis on this side and left it intact here. So what the rectus sheath is it's a tendon. It's a tendon that emerges from the obliques, which are on the sides. And you can see the obliques here. So we can see the fibers of external oblique, and then I can kind of flip that over and we can see the fibers of internal oblique. And then I can flip that yet again and we can see the fibers of transversus abdominis. So in between these layers is a bunch of collagen fibers. And what will happen is they will then branch out and envelop the rectus abdominis in this connective tissue layer that we call the rectus sheath. So when the obliques contract, it kind of tightens and compresses the abdomen. So what's interesting too is when all of those connective tissue layers converge, they converge right in the center and they form this white line that goes right down the center of the abdomen called the linea alba. And it really is a white line. That's what linea alba means. And we can see that right here. So all of this is the linea alba going up towards that sternum. And this is a gap between the muscles. And this is what they're looking for. When they start making their second cut, they want to make that cut through the linea alba so they're not cutting through muscle tissue. So they will reveal away or kind of cut away or remove part of that rectus sheath just so they can see enough of the linea alba to then cut or tear their way through. Again, depends on the specific technique they use, but once they do that, they're then going to meet another layer that's called the peritoneum. And if I flip this over, we can see what this peritoneum is going to look like. And that's what this is right here. This is all the peritoneum on the inside of the rectus abdominis. So then they're going to make their way through this, and that's when they would run into the uterus. So what we're going to do is jump on over to a different cadaver so we can see the uterus and get a better understanding of the next type of incisions that are going to be made. As you can see, the rectus sheath is completely intact on this cadaver, and we've also made an incision that goes around that lower aspect of the abdomen. And I want to be very clear, that is not at all what they do during a C-section. That's something we did in order to be able to see the underlying anatomy. But remember, there's this white line here called the linea alba. So if we had removed that rectus sheath, you'd be able to see that linea alba much more clearly. And what they do is they'd make an incision in going vertically through that linea alba and then separating the two rectus abdominis muscle heads. And as they did that, and as I reflect this back, you can see that peritoneum that I mentioned earlier. They'd have to go through this next. But as I pull this back, we see a giant piece of tissue that you really wouldn't have to worry much about during a normal C-section, called the greater omentum. This is a fatty apron-like tissue that drapes over the intestines. But you have to remember, in a full-term pregnancy, this thing would have kind of gotten pushed out of the way. So they really don't have to do much wrestling with this, but it's a really interesting piece of tissue that I'm just going to fold back, and we meet the small intestines. And again, the small intestines would also be kind of out of the way. You see, the uterus would have pushed them to the side, and they would have also slipped behind the uterus in most cases. So as I pull these small intestines out of the way, we can see the uterus, and that's what this is right here. And obviously it's smaller. I mean, she was in her mid-90s, so we can't expect her to have a uterus the size of a full-term pregnancy. This is pretty cool. We can also see an ovary right here on the side as it connects to this uterine tube. But this uterus, just picture, as they would open this up, they'd cut through the peritoneum, they would see this uterus just jetting out like this. So what they would do, and again, it depends on the procedure, they'll make a cut. Typically, the incision is going to be transverse again, and it's going to then just be in the rough position of where the infant's head is. So they can then birth the infant as well as the placenta, right? They have to get that placenta and amniotic sac and everything else out, not just the infant. But as they birth that, they would then stitch that uterus closed. And sometimes, in some procedures, they even pull the uterus out. And so as they stitch it, they have to kind of put it back in and rotate it and put it into this cavity that you're seeing right here. But again, it would be much, much bigger. And then the intestines and everything would kind of fall around it. I mean, it's obviously the uterus is going to be smaller now that it doesn't have an infant inside of it, but it's still going to be pretty big. But they don't really do much putting of the tissues back because they really only have a small window. The body will take care of most of that by itself. But what they will do, depending on, again, this depends on the technique. Sometimes they will actually, if I put this back, some techniques will stitch and suture this peritoneum closed, others won't. Some techniques will actually stitch the subcutaneous fat closed and others won't. It really depends. But what they have to do, once they've put all the tissues back, they've put the uterus in place, they have to suture shut the integument, the epidermis and the dermis. And when they do that, at that point, the C-section is done. It's really interesting to think about just how far we've come with C-sections. Historically, they were only performed in order to save the baby's life because they came at such a high mortality rate for the mother, they didn't want to do it unless they absolutely had to. But again, nowadays, like I mentioned earlier, we're hovering around that 20 to 30% average worldwide. It's amazing to see just how far we've come. Now, there's something else I do want to briefly mention, and that is something that we're just starting to learn and understand: the effect on the microbiome of the infant as it's born by a C-section. You see, normally as the infant is born through the vaginal canal, mom's vaginal secretions, which are coated in good bacteria, will then coat the infant. The infant will even swallow that, and it will help create a different microbiome population eventually inside of the digestive tract. But when they're being born by C-section, we're finding a completely different microbiome profile. And that's going to be more similar to the skin on the mother, as well as even the operating room itself with which the infant is born. Now, we're still not sure of what consequences this will have later on in life, if any at all. But it's so interesting to note that there's just differences in even the microbiome based on whether it's a C-section or a vaginal birth. I know for me, I'm very interested to see where this will go as we learn more throughout the years. But hopefully this gave you a better understanding as to what's going on with a C-section, or at least the anatomy that they're cutting through as they perform it. Be sure to like, comment, subscribe if you haven't already, and I will see you in the next video.